This is a case of persistent and ultimately disseminated Mpox in a 29-year-old female with an underlying STAT-1 gain-of-function mutation. Mpox is the disease caused by monkeypox virus, which belongs to the genus that also includes the smallpox virus and vaccinia virus. My name is Dr. Jack McHugh, and I'm an infectious diseases fellow and assistant professor of medicine in the Division of Public Health, Infectious Diseases and Occupational Medicine at the Mayo Clinic in Rochester. And the paper I'm going to be talking about today is Mpox in a patient with a STAT-1 gain-of-function mutation. And this paper was written in collaboration with Mayo Clinic Rochester and the Center for Disease Control. Readers may know that there was a large global outbreak of Mpox in 2022. That outbreak ultimately led to over 30,000 infections in the United States of America, and particularly amongst the MSM or men who have sex with men community. Mpox typically presents with fever, myalgias, fatigue, sometimes lymphadenopathy, and that's shortly followed by a rash. The rash is often really painful and itchy and can last for around 2 to 4 weeks. We know that in patients with immunodeficiency, and particularly we've seen this in patients with advanced HIV, the rash can often be very prolonged, lasting for months, and often needs prolonged therapy. This patient didn't have HIV, she had an underlying STAT-1 gain-of-function mutation. That mutation impairs immune signaling and can cause a broad array of infections. And on top of that, she also had a history of splenectomy and hypogammaglobulinemia. And testing while she was hospitalized really revealed quite a pronounced B-cell deficiency, which is in contrast with the typical patients who've had Mpox and advanced HIV, where the deficiency is mostly in T cells. So this patient presented with a rash, and she did receive a 14-day course of tecovirimat, which is the usual treatment for patients who have advanced Mpox. And you can see the evolution of that rash in some of the images. Unfortunately, after stopping tecovirimat, the rash returned, and the infection ultimately disseminated. She was restarted on tecovirimat and received a dose of vaccinia immune globulin. But despite that, the infection went on to involve her GI tract as well as her CNS. And ultimately, she had some seizures and she died of sepsis secondary to Pseudomonas. And at autopsy, we also found disseminated CMV. And some of those images from the autopsy are also available. So reflecting on the case, and I suppose, thinking about the take-home messages, it's really important to consider the host and the immune status of the host when you're treating Mpox. If the patient has advanced HIV, it's important to start antiretroviral therapy. That will be part of the treatment plan for that patient. In patients with other advanced immunodeficiencies, I would really recommend involving the Center for Disease Control, the CDC, at early stages to optimize the treatment plan. There's no FDA-approved agent for Mpox, but there are agents available under expanded access protocols. I mentioned tecovirimat and vaccinia immune globulin. The other treatments that are available are cidofovir or brincidofovir. So in these complex cases, combined therapy may be necessary, and the CDC can really be helpful with coordinating that treatment plan. While thankfully Mpox is not highly prevalent right now in the US, there is, for example, an outbreak currently in the Democratic Republic of Congo. This is a slightly different virus. The Mpox outbreak in 2022 was the clade 2 type, whereas this is a clade 1b. However, from what we know, the vaccine that's currently available does provide good protection for clade 1b virus also, and there may be future outbreaks in the future. So in terms of future lines of research, we really need better therapies. Quite recent research has shown that while tecovirimat may be helpful in patients who have severe Mpox, the benefit is really doubtful in those who have mild or moderate disease. And really all of the treatments that we have should be considered virustatic as opposed to virucidal. And a virucidal treatment could be particularly helpful in a case like this, where we have limited options to optimize the immune status of the host. Thanks for listening to the video. I'd really appreciate if you had a read of the article, and please reach out to me with any further questions.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.